Today's topic for Pathophysiology 2 is integumentary disorders. When I talk about the integumentary system, it really does include your skin, so we'll review the epidermis, dermis, and hypodermis, but it also includes associated glands, hair, and nails. But we're really going to be focusing on the skin for this lecture. The skin covers the entire body, as you know, and it's the largest organ. It accounts for roughly 20% of your body weight. And when we combine skin with the accessory structures of hair, nails, and glands, it forms the integumentary system. The primary function of our skin is going to be to protect us from the external environment, and it helps maintain homeostasis by regulating our fluid and our temperature levels in our body. Today we're going to be looking at dermatitis, papulosquamous disorders, cutaneous infections, and we will finish up looking at skin tumors. First, though, we need to review the normal anatomy of the skin. With this cross-section of the skin here, this being the most superficial, obviously where the hair is, and then moving deeper, we have three main layers. The epidermis is the top layer, dermis is the middle layer, and the hypodermis or subcutaneous layer is beneath that. So the dermis is in the middle, and then epi means on top of, so this is the part of the skin that it lies on top of the dermis. And then hypo means lower than or below, so this is the layer that's below the dermis, that thickest layer. It's also called the subcutaneous layer beneath the skin layer. Now let's look at the epidermis first. If you look closely in this image, you can see a bunch of different layers of cells all through here. We're going to have a look at those layers briefly over here. So this here is your epidermis. So we're zooming in on this structure. And each of the different layers start with the name stratum. We can see 4 shown here. There are 5 depending on what area of the body you're looking at, but stratum just refers to layer. So we have the basement membrane here, which would equate to being along here. So really the part in between the epidermis and the dermis. You can see this layer of cells here, and these are called keratinocytes. Keratinocytes are the most common type of skin cell, and they make up the structural component of the epidermis. And they produce this protein called keratin. So it's a cell site that produces keratin. And keratin is really an intermediate filament protein. You don't need to be aware of that detail for this course, but that might be familiar to you from normal anatomy, that holds the skin cells and the different layers together. Integrity, providing integrity to our skin, or a component that provides integrity to our skin. So these keratinocytes, you'll get more cells that get produced, and as they get produced, they move up. They're moving more superficial to the outer layer of your skin, where they become flat. And you can see how flat these cells are. Squamous is scale-like. The top layer, the stratum corneum, this is the layer of really dead skin cells that are sloughed off. So we continually produce new epidermal cells that move upward and then get sloughed off. Other ones move upward and they get sloughed off, continuously renewing our epidermis. I want to bring your attention to melanocytes. Melanocytes are cells that produce melanin, and melanin is what provides that pigmentation to your skin. It also provides pigmentation to eyes and hair. But what's useful about melanin is that it helps absorb harmful ultraviolet rays, helping really to protect your cells from sun damage. And that's why people that are fairer, like myself, I don't produce as much melanin, and so I'm more predisposed to skin damage from the sun. And then finally, embedded in the epidermis, we have Langerhans cells shown here, and these cells are really immune cells. They act as like the outermost guard of your skin's immune system. And so they are likely to induce some of the first reactions that could occur when pathogens are encountered via your skin. So we have keratinocytes that produce the protein keratin that contributes to the skin's integrity. We have, and really just making up your skin. We have melanocytes embedded throughout, here, that contribute to the production of melanin and protection from the sun. And then we have Langerhans cells, which are part of our immune system. Then moving down to the dermis, we can see that beneath the epidermis, this larger, thicker layer possesses various structures, including hair follicles and sweat glands, and various different sensory components that are allowing for us to get feedback from our environment to our central nervous system. And then beneath that, we have the subcutaneous or hypodermal layer, and this is primarily made up of fat. But you can see throughout the hypodermis and dermis especially that there is quite a vascular layer. You can see all the vessels. What's just an interesting note, when somebody gets a tattoo, it's important that the tattoo artist goes deep enough when they're doing the tattoo to penetrate the dermal layer. Why is that? Well, if they only go as deep as the epidermis, well, we shed that off. So the tattoo will be shed off, quite a waste of money. So it needs to penetrate through to the dermis, which is not renewed in the same way. All right, now on to integumentary disorders. I'm going to be spending quite a bit of time talking about dermatitis or eczema. These terms are commonly used interchangeably, but technically speaking, they would have slightly different meanings, but we're going to be using them interchangeably for this course. Dermatitis, when you see derm, I just want you thinking of the skin. Think of a dermatologist, a skin specialist. Itis, we know, means inflammation. And that's really what eczema is inflammation of the skin. Eczema or dermatitis is the most common inflammatory disorder of the skin. So this is also stated on the next slide, but it's important that you know that. So still on that topic of dermatitis or eczema, and I'd mentioned to you it's the most common form of inflammation of the skin. It is a rather general term, so if somebody tells you they have eczema, after this lecture, what you should be thinking of is, well, what type of eczema do they have? Because it is quite an umbrella term. So general term for skin irritation, but also it can exist in acute, subacute, or chronic phases, all depending on when it comes on and how long it lasts. But usually you will hear acute or chronic in terms of the words to describe eczema. So inflammation of the skin. With the skin being such a large organ that is exposed to the environment, there are many different potential causes of eczema or dermatitis. Now, unfortunately, eczema and dermatitis seems to be the easy label for skin irritation, but it's important to ensure that it isn't something more serious or something that's more systemic, so something that's arising from a systemic condition. And I know even just family members that have been given the general diagnosis of eczema and a topical ointment to treat it, but it goes back a lot further than that. What is it that potentially caused it that needs to be fixed in order to prevent reoccurrence? On the next slide, I'll be talking about the different types of eczema, but just to give you a general overview now of the characteristics that would typically be seen with some cases or many cases of eczema. And it includes pruritus, which is itching. So it's common that people will feel itchy. Erythema is redness, so redness of the skin. The lesions typically have indistinct borders, meaning that it's a little bit difficult to see where exactly the lesion starts and where the healthy, normal skin is. And what's common are these red papules. So here's a papule. A papule is an elevated, firm, circumscribed area that is less than 1 centimeter in diameter. So I'd like you to make note of that, because clinically that's important, that when you see this elevated firm lesion that's less than 1 centimeter in diameter, it is referred to as a papule. And papule can accompany many different skin diseases. Scales. Scales are kind of like a flaky skin. They take on this kind of irregular shape. They can vary in size. And it's really just a bunch of keratinized cells, remembering that keratinocytes make up the majority of our skin. I just want to go back here and mention that when we say the term dermatitis, I'm not just referring to the dermis of the skin, that central layer that I spoke about earlier here. I'm talking about the skin in general. So what are some of the sorts of things that you'll see on the skin? Well, obviously there's changes in what will be considered the normal epidermis. And it can get worse because there's this continued irritation and scratching that can lead to other problems: edema or swelling, a serous discharge, which is like a thin, clear fluid, and crusting can occur. Over time, if these lesions are chronic, the skin can become thickened, almost leathery in appearance. It's not uncommon for hyperpigmentation to occur because of the constant irritation and scratching that occurs with chronic dermatitis or eczema. So let's look at the different types, and this might be best for you for studying to create a chart so that you can visually see what's going to be on the next few slides, all the different types of eczema on one page. Starting off with what's called contact dermatitis. There are two types that are classified as contact dermatitis, and they get their name contact because they involve contact with something specific that causes the dermatitis. Starting with allergic contact dermatitis. Usually allergic contact dermatitis is localized, but it can spread with an allergic reaction. It is a common form of T-cell mediated hypersensitivity, or also known as delayed hypersensitivity. And with delayed hypersensitivity, several hours can pass before an immunologic response is apparent. So you could have somebody that is exposed to something they're allergic to, let's say latex, and they don't get the rash immediately, but it can come on several hours later. And so that is a type 4 hypersensitivity. And with these delayed hypersensitivities, somebody can be exposed to latex and not have an issue, but then they become sensitized, and then their second exposure can create quite an allergic rash. But latex is not the only example. There are many, but just to give you a few listed here, certain metals that people are allergic to, as well as poison ivy, can create an allergic contact dermatitis. Allergic contact dermatitis, you don't need to write this down, but just so that you know that it can be an immunoglobulin E type 1 reaction as well, but you don't need to know that for this course. I just want you to be aware of that type 4 delayed hypersensitivity reaction. Okay, irritant contact dermatitis. This is usually localized as well. It's a non-specific inflammatory dermatitis that's caused by this direct cytotoxic action of the offending physical or chemical agent. So it does not involve the immune system, but it looks like it looks like an allergic contact dermatitis. Severity will depend on what the irritant is, the length of exposure, the age of the patient, what the strength is of that particular irritant. So an acid is going to have more of an effect on causing an irritant contact dermatitis than water, for example. Now, what's interesting, you say water, well, what does that mean? Well, there was quite an uptick in the amount of irritant contact dermatitis throughout COVID because people were washing their hands more thoroughly and more regularly and using sanitizers, alcohol-based sanitizers, a lot. And what this was doing was compromising the epidermal barrier and leading to this irritant contact dermatitis. Now, this would be an example of, let's say, sandals that were worn that caused irritation. Now, in this case, this person may have purchased sandals from the dollar store or maybe from somewhere else in the world, and the chemicals interacted with their skin and caused substantial irritation. So, something comes into contact with the skin and irritates it. No immune reaction with this form. So that's a very important difference. So in terms of treatment, sometimes no treatment is necessary, but in other times corticosteroids are needed, usually topically, to help clear up the signs and symptoms that the person's experiencing. But the good news is when it comes to contact dermatitis, once you remove the irritant or remove the allergen, then the rash will go away. And so once you're aware of that, you just need to stay away from that particular allergen or irritant. So still on the topic of dermatitis, on the last slide I talked about contact dermatitis in the two forms. I'm now going to talk about atopic dermatitis, also known as atopic eczema. This is common in individuals that have a history or personal or family history of eczema, of asthma, of certain food allergies. It is the most common form of eczema in children. So it's more common in infancy and childhood than it is later on in life, although it still can occur later on in life. It has been thought to be related to food allergies in many children. For example, dairy can cause atopic dermatitis in children, and simply removing dairy, although not that simple of a task, because who doesn't love dairy, especially kids, can clear this up. So food allergies should also be considered. Allergic rhinitis is an inflammation of the inside of the nose that's caused by some sort of allergen, such as pollen, dust, or mold, or certain animals. And so if a child has, or someone has allergic rhinitis, then they may also develop atopic eczema or atopic dermatitis. Those with atopic dermatitis are likely to have an increase in immunoglobulin E levels. Now, what does a high level of IgE mean? Well, if somebody has a total IgE test and it shows high levels of IgE, that means that they may have some kind of allergy. But the results of a total IgE test don't show you what you're allergic to or how serious the allergy might be. But if you have a specific IgE test result, it could indicate that the person is allergic to a particular allergen. I'm going to skip over to eosinophilia. Remember, with white blood cells, one of the types are eosinophils. These are white blood cells whose cytoplasms are filled with granules. Somebody with atopic dermatitis is likely to have eosinophilia, which is high levels or higher than normal levels of eosinophils. I've seen this personally. One of my children, when they were very young, when we started them on milk, cow's milk, they started to get eczema, and I wanted to have some blood work done, and I knew that there would be higher levels of eosinophilia that went along with his atopic dermatitis, and sure enough there was. But once we got rid of giving him dairy, especially at a young age, it cleared up his dermatitis even at his current age, which is 9 at the time of this recording. Okay, positive allergen skin tests. These can be done usually with an allergist, where they will test common food and other inhalant allergens to see how the person responds. These images show you some of the characteristic lesions and some crusting from irritation where the child is continuing to scratch. And you'll see quite a bit of that around the knees and the ankles and the wrists, and the face are also common locations. And you'll notice too that when I say the wrist, the knees, and the ankle, these are really the extensor surfaces of the person's body. So these are more characteristic in children. In young children, in adults and older children, it can vary in different areas. It can be, you don't need to make note of this, but it could be the neck, it could be the antecubital area, so in front of, like, not the back part, which is the elbow, but the front part. It can be the backs of the knees and on the hands and the feet, many different locations. One more type of dermatitis that I'm going to be covering is called seborrheic dermatitis. This is a common, usually chronic, even relapsing inflammation of the skin. And it occurs in areas that are rich in sebaceous glands. So where we find sebaceous glands, such as the scalp, eyebrows, eyelids, ear canals, nasolabial folds, which is this region here, the axilla or armpits, chest, and back, have a lot of sebaceous glands, and they can become inflamed and lead to inflammation of the skin in that area, which is called seborrheic dermatitis. So it can take time to develop, and it does not clear up easily. So that's where sometimes it's described as relapsing. The oil combined with chronic irritation can give this almost plaquey, scaly appearance. So it's often described as scaly plaques. And we'll look at what this term plaque means shortly. Cradle cap is what we would see in infants. It's a common skin condition of newborns, and it's caused by overactive oil glands in their scalp. So their scalp will appear very, very dry, and parents will try to put as much lotion as they can, and they'll try to pick off the scaly parts, but that can just make it worse. Now, the cause or etiology is unknown, but proposed etiologies would include a possible fungal infection. Another thought could be immunosuppression. So for example, people that have certain conditions that suppress their immune system might be predisposed to developing dermatitis. So those are just some examples. The mildest form of seborrheic dermatitis is called scalp dandruff. So this is important for you to know. So if you see somebody or know somebody that has scalp dandruff, it's super, super, super common, you would know that they more specifically have seborrheic dermatitis. And it's thought that this is related to a fungus as well, and so some of the shampoos that are created to help combat scalp dandruff would include an antifungal within it. Our next topic is papulosquamous disorders, which are characterized by the presence of papules, hence the name, scales, plaques, and erythema. Erythema remembers redness. Papules and scales I've mentioned a little bit. Papules are these elevated, firm, circumscribed areas that I mentioned are less than 1 centimeter in diameter. Scales are really just keratinized cells, flaky skin that take on this irregular shape and vary in terms of their size. So think of skin flaking, very scaly appearance. Plaques are elevated, they're firm, they're very rough, and you can see that just by looking at it, and they are greater than 1 centimeter in diameter. So plaques are bigger than papules. There are a variety of different conditions that fall under the category of papulosquamous disorders. Even seborrheic dermatitis can be classified as a papulosquamous disorder, but I kept it in the dermatitis component of this lecture. The specific disorder that fits this category the best is psoriasis. Psoriasis is a chronic, relapsing, proliferative, inflammatory disorder that is immune-mediated. It involves the skin, particularly the skin close to joints. It also affects the scalp and the nails. It can occur at any age. In terms of cause, a family history of psoriasis is estimated between 60 to 90% of cases, you don't need to know that specific number, but know that there is a genetic risk factor involved. This condition it's autoimmune, and it involves T helper cells. Remember that autoimmune refers to really attacking the body, attacking yourself with your own immune system. Psoriasis is oftentimes associated with systemic comorbidities. One example of a systemic comorbidity that I would like you to please make note of is Crohn's disease. Crohn's disease is one example of a comorbidity that can be linked to having psoriasis. There are different types of psoriasis, but plaque psoriasis is the most common, and it's characterized by these well-demarcated, so the borders are obvious, thick, almost silvery in appearance, scaly, red plaques. And they're surrounded by normal skin. You can see the normal skin in and around them. So this condition will start off with these small red papules. Now remember that a papule is going to be this elevated lesion that is less than a centimeter or 10 millimeters in diameter. But they can start to enlarge enough that they start to coalesce with other papules, forming these larger inflammatory lesions that we call plaques. So I'll rephrase that in case it helps. We have these, let's say these papules here. These papules can start to get bigger and bigger and then coalesce with each other, forming a larger lesion here that would be described as a plaque. So we can say then that papules are less than a centimeter in diameter, but a plaque would be greater than a centimeter in diameter. What's interesting about skin conditions such as psoriasis is that there can be an area of the person's skin that doesn't have a lesion, so let's say here, and then they get some sort of injury or trauma to the area. Okay, so trauma here. This trauma can cause the formation of papules, which then can form into plaques. And this is called Koebner phenomenon, and this is important for you to know, so please star this. And there is a relationship between psoriasis and psoriatic arthritis. These are distinct conditions, but they can be connected. And so up to a third of people, and you don't need to know that stat, but just be aware of the relationship that up to a third of people with psoriasis will also develop psoriatic arthritis, which is an autoimmune condition affecting joints. Now on to a different topic, acne vulgaris. This is inflammation and bacterial infection of the pilosebaceous follicles. Pilosebaceous follicles are sebaceous glands that are located near a hair or associated with a hair follicle. And these glands become more active during adolescence, and so it's more common to occur in teenagers. And what ends up happening is the sebaceous gland becomes obstructed, and it can cause a lot of pain and discomfort. You would know if you've experienced this yourself. Of potential concern would be that the bacteria that is causing this infection, if it gets out of control, it can spread underneath the skin if not careful. These lesions can become, in certain situations, a furuncle, which is a boil, and these are abscesses of hair follicles. And we'll talk a little bit more about furuncles on a later slide. And fortunately, in most cases, it starts to resolve itself as the body starts to properly balance the secretions. Now on to a different topic, which is cutaneous lupus erythematosus. This is a skin condition, hence cutaneous, that is autoimmune, so the body attacking itself, and it usually occurs in genetically susceptible adults, particularly women, and the cause is not known. Let's break up this word. Cutaneous meaning skin. What does lupus mean? Well, lupus refers to what we're going to talk about soon, which is this characteristic butterfly rash that was originally given its name lupus, which is a Latin word that means wolf because of the wolf-like facial appearance with this rash. And then erythematosus refers to the reddening that is seen with this rash. It is intermittent, so it can come and it can go. The lesions will vary in quantity and size depending on the person and the situation, but oftentimes the rash is seen on areas that are more commonly exposed to sunlight. And that is going to be, if you think about the areas on your own body that are most commonly going to see the sun, it's going to be your arms, your chest even, and then the face. So the nose and the cheeks tend to be particularly susceptible. Now, cutaneous lupus erythematosus can occur just on its own, or it can occur alongside another condition that you've heard of, which is systemic lupus erythematosus. So these are different conditions, but they can be related. So you could have this skin condition on its own, or you could have systemic lupus erythematosus that also causes cutaneous lupus erythematosus. And whereas this condition affects the skin, this condition can affect organs in the body as well. Now moving on to cutaneous infections, so skin infections. Skin infections are very common forms of skin disease, and for the most part, they'll remain localized to the area that's infected, but in more serious cases, it can spread in the area, but it can also develop into really having systemic involvement where it can be life-threatening. The different types of skin infections will include bacterial, viral, and fungal. Remember that our skin has this normal flora, this microbiome that consists of aerobes, yeast, anaerobes, and provides us this protection against pathogens that could lead to infection. But very commonly, our microbiome can be disturbed in a variety of different ways that can predispose us to infection. So I'm going to start by looking at viral infections of the skin, and we're going to look at herpes simplex, herpes varicella, also known as chickenpox, and herpes zoster, also known as shingles. The two main forms of herpes simplex are oral, HSV1, or genital, HSV2. And that, of course, pertains to the location that these viruses tend to inhabit. Vesicles form that contain fluid, and within this fluid is the virus. They'll form on skin and mucous membranes, and then if those vesicles break and the fluid and therefore the virus is released, that's how transmission to another person can occur. And viruses in this form, herpes, they are quite smart, because what they'll do when you have an initial infection is the virus is going to infect epithelial cells. Then it's going to embed itself in sensory nerve endings. Then it's going to take a little trip, and it will eventually move by what we call retrograde axonal transport, so moving backwards along the axon to where it travels to the dorsal root ganglion. And so even after somebody's not showing symptoms that they have or signs that they have a herpes simplex infection, the virus is within their dorsal root ganglion. And so during certain times of stress or injury or fatigue, among other things, the virus can be reactivated. And what it will do is it will travel down along the peripheral nerve to the site of the original infection, where it shows itself and is shed. So when it lives in this dorsal root ganglion, the virus develops lifelong latency. Next up is the herpes varicella virus, also known as chickenpox, also known as human herpes virus 3. Infected individuals will have vesicles that are present all throughout the body, skin, mucous membranes, that can burst and then spread. And so it's what's within those vesicles that is contagious, just like with herpes simplex. So highly contagious from one person to the other, and is even airborne as well. Most cases of chickenpox are uncomplicated and don't require any therapy, just time to recover. And there is a vaccine available for chickenpox now, or there has been for a while. So the thing though with herpes, as already mentioned, is it will stay dormant. once you've recovered from the initial infection. However, under times of maybe stress, or if you're immunocompromised, many different possible thoughts, the virus can make its way back out, but it presents differently when it comes back out. It doesn't present as chickenpox anymore. Instead, it presents as shingles. Still a varicella zoster virus, still human herpes virus, but a different presentation. This is more commonly seen in adults. And it appears, when it appears on the skin, it appears along dermatomes. So a very interesting pattern. And it'll follow the path of that sensory nerve, and it will be extremely painful for the person experiencing it. Very different than what that person would have experienced with chickenpox. What I want you to make note of is the most commonly affected dermatomes when it comes to herpes zoster, also known as shingles. So please make note that the most common location is the lumbar and thoracic area and the dermatomes that supply that area of skin. So lumbar, lower back area, and thoracic or upper back area. And interestingly, it rarely crosses the midline. It's usually just one side. And there is a vaccine available for shingles as well. So how does it work for the spreading? Can somebody with active shingles, with vesicles that contain the virus, can they spread shingles to somebody else? No. What happens instead is if there's a patient that has shingles and I come into contact with that patient, and if I've never had chickenpox before and I've never been vaccinated against it, then I can actually become infected, but I won't develop shingles. Instead, I'll develop chickenpox. Still on viral infections of the skin, looking at rubella, also known as German measles or the 3-day measles, and then measles. Now rubella, this is a very mild, for most children, viral infection that can show up on the skin, but also have other symptoms, cold-related symptoms. And once you have rubella, you've been vaccinated against it, you have immunity to it. And especially with a naturally acquired infection of rubella, you may have lifelong immunity after that infection. So while rubella is not a concern for most people, and while most kids will get rubella, it is a concern for pregnant women if that mother has not had rubella. So let's say you have a pregnant person, they have never had rubella and they weren't immunized against it, and they have no idea what their status of immunity against rubella is. And they come into contact with a young child who has rubella, and they become infected themselves, that pregnant person, with rubella. They will be fine, but it can cause fetal death and congenital defects in the first trimester of pregnancy especially. So when kids are vaccinated for rubella, most of the time it's to protect any pregnant women and their unborn baby that they might be around. Now looking at measles, so this is different than German measles or 3-day measles, that is rubella. Measles is highly contagious, an acute viral infection that can spread directly through droplets. In many cases, when somebody is infected with measles, they will come out of it okay, but it can be complicated in those that are immunosuppressed, especially in those children that are susceptible to developing pneumonia, as measles can lead to pneumonia, and if that child can't recover from the pneumonia, then it can be life-threatening. So not measles in itself that is problematic as much as the complications that can arise, especially in those that are immunocompromised. And measles can infect the mucous membranes as well. And what's interesting is a lot of these rashes can clinically present very similar, as you can see from these images. So that was all viral. We're going to look now at bacterial infections of the skin, looking at furuncles or boils, which I mentioned earlier in this lecture, cellulitis, and impetigo. Furuncles involve inflammation of the hair follicle that leads to quite an infection. And it can start off as folliculitis, so whether it's a follicle on the face that becomes acne vulgaris, as mentioned earlier, or somebody can just have folliculitis, inflammation of the hair follicle on their arm, and they try to pop it. And irritating it can cause it to become a furuncle. So it's really an abscess that's present in the dermis that puts pressure superficially so it can be seen and felt. If somebody has multiple furuncles in one area, they can coalesce together and form what's called a carbuncle. Interesting names. Cellulitis is an infection and inflammation of the skin, and it is more disseminated, affecting the dermis and the subcutaneous layers, so throughout here. And when I say disseminated, I mean it's kind of spread in an area, not just one pinpoint area, but spread throughout an area, and it can continue to spread if it's not kept under control. And one of the biggest problems with cellulitis is that if it is not treated, this bacterial infection, it can spread rapidly, so become more disseminated and get into the blood, causing bacteremia or septicemia. And so infection, pathogens present such as bacteria in the blood, means that it can spread to other areas of the body and set up shop. You could have somebody that gets bacteria in their blood from cellulitis, and this bacterial travels to the lungs and causes a lung infection, for example. In some cases, somebody can have this persistent furuncle or boil, looks like just a pimple, say on their skin, maybe on their leg, and they continue to pick at it and it gets more irritated and bigger. It can cause spreading into the skin around it, leading to cellulitis. And finally, impetigo. This is the most common bacterial skin infection in children. It's very contagious, and it causes these superficial crusted lesions, as you can see here, that can continue to spread. So it can get bigger and bigger and bigger throughout the area that it is causing an infection. So prompt treatment's required to avoid complications. This can lead to so many complications, including issues with the kidneys. It can cause, if you've heard of necrotizing fasciitis, septic shock. It can be serious and usually would be treated not with a topical antibiotic, but an oral antibiotic, just to be sure you're getting all of it. And actually, I had forgotten that I had a picture of cellulitis here to show its disseminated presence, whereas the furuncle here is more localized. The impetigo is localized here, but it can become disseminated as it spreads throughout. To tell you a story about my own personal experience with a family member with impetigo, one of my kids, who a long time ago when he first started kindergarten, like many kids, he would lick his lips during the fall months as it got colder. And he had licked his lips so bad, they were crazy chapped and cut and bleeding. Anyways, he must have touched something at school and then touched his face and contaminated his lips with either Staphylococcus aureus or Streptococci, so these being the more common bacterial strains, and it looked horrendous. It continued to spread all up his face from his lips, and so pretty quickly, and we identified what it was and got him on oral antibiotics to get it under control. So something so simple as licking lips, and then kids in kindergarten, no matter how much you teach them to wash their hands, they're still touching everything and always touching their face. So it can be pretty easy to spread in children for that reason. Fungal infections. So we've talked about viral skin infections, bacterial skin infections. Now we're going to look at fungal infections of the skin, and we're going to look specifically at ringworm and the different types of ringworm that exist. Ringworm is considered a dermatophyte infection. Dermatophyte is referring to a pathogenic fungus that can grow on the skin as well as like mucous membranes, hair, etc., that cause ringworm and other related diseases, but ringworm is what's important today. Ringworm is considered a superficial mycosis, which is just a disease of the skin caused by a fungus. Funguses, they are not very virulent. They're not very strong, not very aggressive. They tend to remain superficial. They like warm environments. So warm environments is more likely where somebody's going to pick up a fungal infection. But even though they're not very virulent and not very aggressive, they can persist. The examples that we'll look at today are tinea pedis, capitis, corporus, and unguium. Tinea pedis is also known as athlete's foot. This is a term referring to the feet. Well, tinea is a word that's used when we're talking about ringworm. And actually, one of the other things I wanted to mention before talking specifically about athlete's foot is that these conditions, these superficial fungal infections of the skin, tend to really affect the epidermis. And remember that the epidermis is not vascularized because we constantly shut it off. And so our immune system can't really get to this area. So with tinea pedis, it affects the feet, as already mentioned, common to catch it in showers, pools, locker rooms, kids that are taking gymnastics, and that's because of the bare foot on a warmer floor. Commonly treated with a topical antifungal ointment. Tinea capitis, think cap on your head, is a scalp ringworm. It affects the head, obviously, causing these itchy lesions on the scalp. It is more commonly acquired from contact with infected animals. So sad to say, kittens and puppies fall into that category. So if they, especially strays, people that are picking up a stray kitten can catch tinea capitis from that animal. So the question is, we said that with tinea pedis, or I said that topical antifungal treatments are oftentimes given. But what about with tinea capitis? The answer is usually topical does not work with tinea capitis. And the reason for that is because the topical treatments don't often penetrate through the hair follicle. So remember, because we're talking about the scalp. And because those topical treatments can't get to the hair follicle, it's likely that the topical ointment is not going to work on that person. So oftentimes treating it systemically with a systemic antifungal might be required depending on the case. Tinea corporis refers to the trunk. This could be trunk ringworm or body ringworm. Can also sadly be caught by exposure to infected kittens and puppies, and topical antifungal treatments do tend to work. And then finally, tinea unguium. Please make note that this is a fungal infection affecting the nails. And I'd also like you to make note that it usually requires systemic treatment as well versus topical antifungal treatment. So we're looking at tinea pedis and corporis that tend to respond well to topical antifungals, and tinea capitis and unguium tend to respond better to systemic antifungals. Continuing on with fungal infections of the skin, but now looking at candidiasis. Candida causes many fungal infections in humans. There are at least 15 different species of Candida, but Candida albicans is the most common. Candida albicans is found normally colonized, so this is part of our normal microbiome in the skin, in the mouth, in the intestinal tract, in the vagina. But the body does a great job in keeping these microbes in balance, and if we have too much of Candida albicans, it can lead to candidiasis. Common location where this yeast infection occurs of the skin and or mucosa includes skin folds, where it can lead to these red itchy lesions. So this could be, actually this can occur in people that are overweight, that have skin folds. And underneath those skin folds, it's a warmer environment where we know funguses like to be, and it can cause quite a lot of irritation. It can also occur in mucous membranes. In the mouth, it can cause this white coating that's known as thrush. This can occur in babies. And then with the vagina in particular, a yeast infection can cause a yellow discharge. Just like in other mucous membranes, the vagina contains good bacteria that help keep everything in balance and help ward off any pathogens. But if the good bacteria gets wiped out for whatever reason, it can lead to an imbalance now where Candida albicans can overgrow, leading to a yeast infection. One of the ways that this can occur is with antibiotic use that cleans out good bacteria that can predispose a person to a yeast infection, but also something as simple as cleaning the vagina with soap. Soap is not needed to clean the vagina. It cleans very well just with warm water and healthy lifestyle choices. Soap will kill off some of the good bacteria that helps keep things in balance, predisposing somebody to a yeast infection. Another consideration clinically would be young babies, especially if it's parents that are first-time parents, and they have a daughter and they're not sure how to properly take care of the vaginal area, especially when you have various different substances within a diaper. How do you properly clean the baby? And so if too much soap is used or certain wipes are used, this can disrupt the normal environment, causing a yeast infection in babies. And then treatment would be with use of antifungal medication, which can be topical depending on the particular infection. Now on to skin tumors. Talking first about keratosis, which involves proliferation or proliferative growth of the keratinocytes that make up our skin. We're going to look at seborrheic keratosis, so don't get confused with this and seborrheic dermatitis, and actinic keratosis. Seborrheic keratosis is benign proliferation of basal cells. Remember the basal cells, you might recall, are the most bottom layer of cells that are part of the epidermis. That's the basal cells. Remember the stratum basale, if that helps. And they more commonly form, this condition most commonly forms in areas where sebaceous glands are present, hence the name seborrheic keratosis, because seborrheic relates to sebaceous. And they give this appearance of smooth or even warty elevated lesion. They're oftentimes brown, they can look a little bit waxy. Sometimes people describe them as almost like a sticker that they could just peel off in terms of its appearance. Now they can look like melanoma, malignant melanoma, which we'll talk about coming up later, but it is not melanoma. It's very different. Seborrheic keratosis worsens with UV exposure and age, so you will likely see many of these lesions in people as they get older. Again, especially in areas that are exposed to the sun. So in men that don't have hair, as they get older, they can develop these on their head, for example. Now, the question I have to ensure you know the answer to is there a risk of skin cancer with seborrheic keratosis? And the answer is no. So please make note that there is no skin cancer risk. People will be worried about these, but as long as they're checked out and confirmed that they are in fact a seborrheic keratosis, sometimes called a SEB-K for short, then they don't have to worry about them becoming cancer. And some people will choose to have some of them removed, generally for cosmetic purposes. So they are considered harmless. Actinic keratosis. This is proliferation of keratinocytes due to exposure to UV rays, so ultraviolet rays. It's also known as solar keratosis. It is seen most frequently in those that have fair skin that don't use sun protection. The lesions appear as sort of these roughish, scaly, kind of poorly defined, pink or reddish. Sometimes they can have a brown color to them in areas that are most commonly exposed to the sun. Sometimes, and because they are a papule and sometimes even scaly, they are palpable. And because you can palpate them, that might be the only reason somebody knows it's there. It could be so similar to the person's skin color that they don't really notice them, but they feel the roughness that is associated with this skin condition. So the question with this is there an increased risk of skin cancer? And the answer is yes. It is considered to be precancerous or premalignant. So if left untreated, actinic keratosis can develop into skin cancer. And the specific skin cancer that I'd like you to write down, and you'll see this on an upcoming slide, is called squamous cell carcinoma. So to say that again, actinic keratosis, greatest risk is people that are exposed to the sun and that are fair skinned because they don't have as much melanin to protect their skin. There is an increased risk of these transforming into squamous cell carcinoma. And that's why once it is identified, it should be removed. So premalignant. And I should say too that actinic keratosis is not skin cancer, but it's considered precancerous. Next up is a few more growths on the skin, including keratinoacanthoma and nevi, also known as moles. Keratinoacanthoma are considered benign and self-limiting. Self-limiting meaning that if you look at its natural history, is likely to resolve on its own without treatment. So it's growth of squamous cells, the flat cells as part of the skin, arising from hair follicles. It can look like a wart in those that are affected with it. It's more common in males, more common in older adults, also more common in smokers. But also, like many skin conditions, UV exposure is considered to be a risk factor. And so going on with our trends here, is there a risk of skin cancer? The answer is possible. Usually it will clear up on its own, but if it doesn't and it continues to persist, it is possible that it could transform into skin cancer. And just like what I discussed on the last slide, the type of cancer it could potentially transform into is a squamous cell carcinoma. So what will happen with this condition with keratinoacanthoma is it will proliferate. You'll get this proliferation, and then it starts to mature, and then it will, in a lot of cases, the self-limiting component is it will involute. But because there is that possible risk of it becoming squamous cell carcinoma, these are usually just removed as opposed to waiting to see what happens. All right, nevi, or what you know of as moles, they're considered benign. They can be pigmented, which is what you would normally associate with a mole, or they can be non-pigmented, but they're made up of melanocytes, those melanin-producing cells. What's key when it comes to moles is that there is even pigmentation throughout the mole. And we're going to see this on a later slide. We want to see that the borders are very defined, very clear, not blurry. Sometimes a hair will grow out of a nevi. That's not uncommon. And what about risk of skin cancer? It's also possible. You've probably heard, if you or someone you know has various moles on their body, they've probably been told to be careful and have them checked to ensure that they're not transforming into skin cancer. So let's have a look at the difference between a mole that is normal, or it is just a nevi, what we call a pigmented nevi, a benign mole, or is it a malignant melanoma? And a malignant melanoma is the worst form of cancer. And with this type of cancer, it can spread to other areas of the body. So this is the worst form of skin cancer. So how do you tell the difference between a mole that is benign, made up of melanocytes, versus one that is cancerous? With, by the way, the cause being, in most cases, UV exposure. So protect yourself against the sun, no matter your skin color. ABCD used to be part of the acronym. This used to be the acronym that was used for identifying the differences between a normal mole and one that is malignant melanoma, and now E has been added in for evolution. So let's have a comparison here. We have normal benign mole on the left, and then we have malignant melanoma on the right. A stands for asymmetry. Well, you can see this is symmetrical. This is not symmetrical. The border, we want the border to be clear. The border here is more blurry. The color, we want generally one color. Here you can see there are different shades, which is not good. Diameter, and oftentimes using the back of a pencil, the eraser at the back of a pencil can help gauge size, but anything greater than 6 millimeters should be looked at. And then evolution, is it changing over time? Sometimes moles are just observed over time, and if they are changing, that can be indicative of malignant melanoma. Now, just because you have a mole that looks like any of these doesn't mean it is malignant melanoma. It just means it should be looked at by a dermatologist. So I talked about some benign growths of the skin. I talked about how some of those benign growths can become cancer or would be considered precancerous. I talked a little bit about malignant melanoma, but now what I'm going to talk about is the two other main forms of skin cancer, but they are also called non-melanoma skin cancer. So if you think about it like this, there are three main types of skin cancer. Malignant melanoma, which is the worst form that can spread and metastasize throughout the body. And then we have basal cell carcinoma and squamous cell carcinoma, both of which have a much, much better prognosis. Basal cell carcinoma, please know, is the most common cancer in the world. Cancer. Very, very common. I have multiple family members myself that have had a basal cell carcinoma removed, caused by primarily exposure to ultraviolet radiation. And it originates, hence the name basal, from undifferentiated basal cells. So thinking back to, actually I have it here, the epidermis consists of those strata. And the bottom one is the basale, also known as the germinativum. And this is where these cells will end up being sloughed off eventually, as talked about at the start of this lecture. They can have various different appearances, and this is where you ideally have a specialist that has a look to confirm, so a dermatologist. They can have this pearly or ivory appearance. It's not uncommon for in that area for there also to be what's called telangiectasia. Telangiectasia, these are shown here. There's small widened blood vessels on the skin. Just because these are present doesn't mean there's a problem. They are common with many different conditions and are generally considered harmless, but they can be associated with certain diseases or conditions, just like in this case, they can be associated with a basal cell carcinoma. Basal cell carcinoma is considered to be invasive, so it can invade tissue in the area, but it's generally very slow growing. And I'm going to come back to that. In terms of risk of metastasis, it is very rare for this to spread. In almost every case, it will just remain in the area that it originated rather than spreading to other areas of the body. But here's the thing. They are very invasive. They will invade the tissue in the area, and while this looks like a very small lesion, the cancer is actually significantly bigger than that. And because of that, When the cancer is removed, they must remove all of the cancer and some of the normal tissue around it. So it can be very disfiguring, especially if they're found on areas such as the face, which is the most common area exposed to sunlight. Squamous cell carcinoma. This is a carcinoma of the epidermis. It's caused by the flat cells as part of the epidermis, primarily as well caused by sun exposure. It's the most common cause of lip cancer. I mentioned earlier to you that there are 2 premalignant lesions. So the lesions themselves that I spoke about are benign, but they're also considered pre-malignant or precancerous, and they could transform into squamous cell carcinoma. And maybe you can pause the video and try and remember on your own what these 2 are, but they are actinic or solar keratosis and keratoacanthoma or keratinoacanthoma. Risk of metastasis is also rare, a bit more of a risk than with basal cell carcinoma, but overall very rare, and they're usually caught and removed before they could potentially spread anywhere. But malignant melanoma, absolute high risk of metastasis if not caught very quickly. Vascular malignancy. I'm going to talk about this is a cancer affecting vessels, blood vessels, and the one we're going to talk about is called Kaposi sarcoma. Kaposi sarcoma is a vascular malignancy that is associated with immunodeficient states. So when somebody, for example, with AIDS, where their immune system is incredibly suppressed, are more likely to develop this type of cancer called Kaposi sarcoma. And when you're immunodeficient or immunosuppressed, it allows for opportunistic infections, which we know where we can have pathogens that under normal circumstances would not be able to cause any problems, but when immunosuppressed, they can take the opportunity to create an infection. So those that are immunosuppressed more likely to have opportunistic infections as well as malignancies such as Kaposi sarcoma. So where can we see this? Well, I mentioned AIDS already, and this really is a cardinal sign of AIDS when people present with Kaposi sarcoma, which can sometimes almost look bruise-like, but they can vary in presentation from macules, which are different than papules in that they're flat, whereas papules, remember, are raised. And then nodules, another term where it looks like it's like a pretty defined bump under the skin. But macules are very common with Kaposi sarcoma. Another example would be, let's say somebody has a transplant done. The concern about transplants is that the body's own immune system will look at that transplanted tissue and say, hey, that's not mine. Let's create this reaction against it and reject it. And so in cases where there is this risk of transplantation rejection, drugs can be given to suppress the person's immune system so that they don't reject the transplant. But in doing that, they're putting a person at risk of opportunistic infections and malignancy. So appearance, I had mentioned, they kind of look bruise-like, so that's purplish brown macules, those flat lesions. They can also form the nodules, but they can also form plaques. So there's different presentations. With AIDS, it can progress pretty rapidly and symmetrically throughout the body and even within the oral mucosa. Many will also have involvement within the lymph nodes in the gastrointestinal tract and the lungs, because a vascular malignancy is not just your blood vessels, but can also be your lymphatic vessels. Just an incidental or side note, this should be recalled from when you learned about cancer in this course, but a sarcoma is a cancer of connective tissue, and vessels are connective tissue. Whereas carcinoma, as mentioned on an earlier slide when I talked about basal cell and squamous cell carcinoma, carcinoma infers cancer of epithelial tissue. And the final note to make here about Kaposi sarcoma is that the cancer itself, the malignancy, is actually caused by a virus, human herpes virus 8. So to repeat and rephrase what I mentioned earlier, is that those that are immunosuppressed for whatever reason, particularly seen in those with AIDS and post-transplantation, but AIDS for sure, and very often, is that they're immunocompromised and they become infected with human herpes virus 8. Normally, this is not something that would cause a problem, except when it can take the opportunity to do so in those that are immunosuppressed, and then it can transform into a malignancy. So that's the end of the main content for integumentary disorders. Oh, and these are usually asymptomatic. They'll have the signs, but not really any symptoms. They won't really be in pain, generally painless. I would like you to watch this video on your own time. This talks about melanoma. It's a very, very great, short, moving video. And then a side note about SPF. SPF stands for sun protective factor, and it refers to really this theoretical amount of time that you can stay in the sun without getting sunburned when you put SPF on your body. So for example, an SPF of, let's say, 15 would allow you to stay in the sun 15 times longer than you could without protection. But the question might be when you're in the store, well, what SPF should I buy? And I hear a lot of people say, well, might as well buy SPF 60. I want to protect my skin more than SPF 30. Or I'll have people say the other way around, where I want to get a little bit of a tan, so I'll buy SPF 30 instead of SPF 60. But what a lot of people don't know is that an SPF of 15 blocks out 93% of UVB rays. SPF 30 blocks out 97%. SPF 50, 98% of UVB rays. So you can see that the jump from 30 to 50 is very minor. So if you go to a store and you see SPF 60, 70, 80, 90, really not that much of a difference between buying 30 and 50. But there's another consideration here as well, is that UVA rays can also contribute to the development of skin cancer. And so you want to make sure that you're wearing a sunscreen that protects against both UVB and UVA. Most will protect against a little bit of UVA rays, but you want the most protection as possible. And unfortunately, the best protection is staying out of the sun entirely. But of course, that can be challenging to do, but do your best to protect yourself. That's the end of this lecture. Thanks for your time.